Welcome to Plugged Into Long Island on 102.3 WBAB and 106.1 BLI. I'm Al Levine. I'm joined with Dr. Kapoor, president of Advanced Urology Centers of New York. Good morning, doctor.
Good morning.
So we're here to talk today about prostate cancer, and I want to get a brief overview of your background first of all.
Thank you. And I want to thank you for having me out this morning to share this important subject. Around Father's Day, we like to bring everybody's attentions to their the male loved ones in their family, whether it be their fathers, their husbands, their brothers, and even themselves when it comes to talking about prostate cancer. So I'm president of Advanced Urology Centers of New York. We're the largest urology group practice in the United States. We operate in 8 counties in New York. We have about 1.3 million active patients, and we have 55 locations in 8 counties throughout the greater metropolitan New York area. I'm also the founder of the Integrated Medical Foundation, which is a not-for-profit organization that's dedicated to enhancing and promoting awareness of early detection for prostate cancer and providing resources to men that have been diagnosed with prostate cancer as well as to their families to help guide them through decision-making and the treatment process.
So men cringe when they hear about this topic, but it's a pretty important one to pay attention to. Why should men be thinking about prostate cancer prevention and detection?
Well, prostate cancer remains the most commonly diagnosed solid tumor in men. This year, nearly 221,000 men are going to be diagnosed with prostate cancer. That's a decline from previous years, but it still is one of the most commonly diagnosed disease known. And unlike the impression that some people may get by reading the news or some aspects of the internet, prostate cancer is not universally an indolent or slow-growing disease. Prostate cancer is the second leading cause of cancer death in men. And despite all the advances that we've made in diagnosis and treatment, this year alone, nearly 28,000 men will succumb to this disease.
Anytime you hear the word cancer, you kind of take a step back. You're hearing that from the doctor. Would you say that this is one of the more treatable cancers there are out there?
Yeah, and that's exactly one of the great tragedies, is that virtually every death from prostate cancer could be prevented if the disease was caught early enough. It really is one of the precepts of medicine and cancer therapy in particular, that if we catch a disease process earlier on, it becomes much more treatable. That concept seems to be being discredited by certain aspects of society. And in fact, it kind of is confusing for those of us that treat prostate cancer on a regular basis.
So I've been reading and hearing things about controversy concerning early detection. What's that all about?
Well, the controversy originated some years ago when an entity known as the United States Preventative Services Task Force, which is a mouthful, but we'll call it the USPSTF for short. The USPSTF looked at available literature that existed, and after they review, they came out with a blanket one-size-fits-all recommendation that no man should get a PSA testing to help in the early detection of prostate cancer.
Wow.
Yeah, that was really somewhat of a surprise. Now, to be fair, the data surrounding prostate cancer screening is a little bit controversial. There were the USPSTF looked at 2 very large studies. One is called the PLCO trial, and the other one is called the ERSPC trial. And those 2 trials produced somewhat contradictory information. The problem is that both those studies, even though they were very large, one of them had somewhere in over 80,000 and the other one actually had over 160,000 patients that were enrolled, both of them had problems in the way that they were designed. So, for example, the PLCO study, which was the study that did not show a survival benefit to screening, in that group, instead of comparing screening against no screening, they compared screening against something known as usual treatment. So, in essence, more than half the patients in their control group got screened. The problem with the ERSPC study is that it was a multi-country study, and so the specific screening and treatment protocols that were used were not the same in every country. Regardless of that, the bottom line is that you had the two largest studies produced essentially opposite conclusions. And rather than saying that the data was indeterminate and that we need to do more research, the USPSTF took a very unusual step and recommended banning PSA, or recommending, not so much banning, but that no man get a PSA test, regardless of their individual risk factors, such as, for example, race or family history of prostate cancer, which is universally known to be a very strong risk for developing the disease.
So they expected, without the PSA test, some other indicator to step in and provide a doctor with the wherewithal as far as whether to treat or not?
Well, sadly, there really isn't any other indicator. So
how did they come up with that? I mean, I understand the process of how they did exactly, but why would they think, or how would they think this could be treated or detected otherwise?
Well, the USPSTF conflated the risks of diagnosing prostate cancer with a biopsy and treating prostate cancer with surgery or radiation or however the methodology with screening. Now, fundamentally, there's no risk to screening at all. It's just a blood test and a simple examination that can be done. So other than getting a little bruise or bleeding from a needle stick, there's really no risk at all. But what the USPSTF said was that if you get a PSA, then you're going to get then you may get a biopsy, and then you may get treatment, and that for a certain percentage of men, prostate cancer is a slow-growing disease, and the risk to men of getting treatment that they don't need outweighed any survival benefit for catching disease early. So in essence, the USPSTF, which is a fundamentally unaccountable government agency, told American men that you don't have the right to make your own healthcare decision based on your blood work. We think that this blood test is going to harm you, and so you shouldn't have access to it. Now, in the past, the USPSTF was purely an advisory body. But under the Affordable Care Act, it's been given broad, much greater powers, and Medicare can use USPSTF determinations to make payment decisions. So as a consequence, what we've seen is some national organizations and insurance companies have adopted the USPSTF policy. Recent studies that actually came out just this month have shown that the percentage of men that are being screened for prostate cancer has declined dramatically over the last couple of years since the USPSTF issued its final recommendation. Furthermore, even though it's still going to be diagnosed in 221,000 men this year, the number of patients that are being biopsied and the number of new diagnoses of prostate cancer have also dropped precipitously in the last few years as well. Now, Al, if the only patients that were not being biopsied were those patients with slow-growing disease or indolent prostate cancer, well, that would validate the USPSTF recommendation. Unfortunately, that's not what we're seeing. The overall, in the decreased number of prostate cancers that we're diagnosing, it's not just very low grade, very small volume, in other words, very low risk cancers that are not being diagnosed. We're seeing a significant reduction in the number of high risk cancers that are being diagnosed. Those patients that will go on to develop metastatic and possibly life-threatening illnesses. So since we're seeing a decrease in the number of high-risk patients, what we've also seen is a shift to what we call the hazard ratio for being diagnosed with high-risk prostate cancer when you're newly in new cases has gone up dramatically. So what does that mean for men? That means that if you follow the USPSTF recommendation and not be screened for prostate cancer, when ultimately somebody finds some reason to do a PSA test on you or examined or picks it up for a rectal exam, the chances that you're going to have disease that's in a more aggressive, higher stage, less treatable position is much greater. And what's really frightening is that the data has shown that, now, to be fair, it's only been a couple of years. Urologists have predicted, myself included, a public health crisis. We didn't expect it so soon. Now we haven't seen an increase in death rate yet because it's only been 3 years since the recommendations have been out. But given the fact that the cure rate for these higher risk cancers that we're seeing a higher percentage of, it's now predicted, and different studies have different data, anywhere from a 5 to 13% increase in prostate cancer specific death in the United States.
Wow.
Now, that's really significant because this is the first time in 20 years that we've seen any increase in the potential for any increase in prostate cancer deaths. Now, if you look at it, PSA test was approved by the FDA in 1986. Now, let's look in the pre-PSA era, in the 1970s and 1980s.
Okay.
At that period of time, the 10-year survival from prostate cancer was less than 70%. Take a guess, Al, what the 10-year survival is now. 99.9%.
Huh.
I'll say it again. 99.9%
Wow.
is the 10-year survival for newly diagnosed prostate cancer. That is absolutely extraordinary.
Yeah.
And to completely discount the role that early detection has played is just a huge mistake. Over the same interval of time since the early 1990s, we have seen a 40% decline in prostate cancer-specific mortality. That's just unbelievable. And to simply do away or ignore all that epidemiological data really doesn't make any sense. And I think one of the things that's really most telling is that the week after the USPSTF issued its preliminary findings, its preliminary recommendations that nobody screen for prostate cancer. And remember, the USPSTF is part of the executive branch of the government. President Barack Obama had his PSA done. So my question is, if it's good enough for the President of the United States, why isn't it good enough for every other man in the country?
Now, because of all this, Dr. Kapoor, does this mean that this is not going to be covered in some people's insurance policies? They're not going to be able to take these PSAs without having to pay extra for them?
Well, that's what we're concerned about. We're already seeing that in certain cases. And I will tell you that right now, there is legislation in place in Congress to reform the way the USPSTF does business. And it's bipartisan. It's not Democrats or Republicans. There are co-sponsors,
Sure.
Congresswoman Blackburn from Tennessee and Congressman Rush from Illinois on either side of the aisle have realized that this is not a political issue. This is a health issue.
Right.
And what men need to understand is that having a PSA doesn't obligate you to have a biopsy or, if cancer is found, to automatically undergo treatment. It's simply a piece of information that can be utilized for men to make the best informed healthcare decisions for themselves with discussion with their families and their doctors. And furthermore, Al, what we've seen over the last few years is a vast improvement in how we handle PSA testing.
Mm-hmm.
There's no question that PSA as a standalone test is not without its problems. PSA, which means prostate-specific antigen, is prostate-specific. It's not prostate cancer-specific. Mm-hmm. So as a consequence, even though it's a very good marker, particularly for people that have already been treated, there are benign conditions that can produce elevations of PSA. And in those cases, we may subject men to unnecessary biopsy. In addition, some of those men, without question, are going to have indolent slow-growing disease for whom immediate therapy can be deferred. But now we understand the biology of PSA much, much better. There's a variety of newer ways to interpret PSA known as PSA derivatives. We have genetic testing that can identify men with specific chromosomal abnormalities that may put them at greater risk for cancer. Mm-hmm. There's molecular and genomic tests that occur in the blood and in the urine that can be used in conjunction with PSA to help target who should be biopsied, and if biopsied, who can safely defer treatment, and more importantly, who cannot. So men need to understand that the USPSTF recommendation, it was inaccurate even when it came out, but now really is irrelevant to their own health. Men need to take control of their own of their own healthcare destiny. And they need to understand that you shouldn't wait for a government body to tell you what's best for you. You should have a conversation with your doctor. And I'll tell you categorically, based on consensus recommendations right now, I recommend that every man at some point in time in their 40s, probably around 45, give or take, maybe a little earlier for people at high risk, maybe a little later for people without those risk factors, have a baseline PSA. Once the baseline PSA is obtained, using that baseline PSA, the person should talk to their doctor about their specific risk factors. And what are the risk factors for prostate cancer? There's three biggies that we talk about. Number one, family history of prostate cancer. If you have a first-degree male relative that had prostate cancer, your chance of prostate cancer is much greater than the baseline in the population. Number two, if you're of African-American descent. People of African-American descent, even though we've seen a big improvement in death rates and improvement in treatment, still have a significantly higher mortality than their white counterparts. So it's really important for African Americans to make sure that they're educated about their prostate health and get that baseline PSA. And there's some evidence that says that our veterans that were exposed to Agent Orange may be at increased risk. So once you establish that, and perhaps you get some initial genetic testing done or some of these molecular markers that help stratify it, you can then determine when the next time is. It may be that you don't need another PSA for 5 years. Maybe you need another one in a year. Maybe you need a biopsy right away. But that's not a decision that's a foregone conclusion based on the blood test. You take the results of the blood test, you do some research on your own, you talk to your doctor and your family, and then you come up with a strategy for your own health maintenance that's individualized and personalized to you, not the one-size-fits-all recommendation that the government has put forth for you.
So the bottom line here is get yourself screened. This piece of information can be extremely helpful in determining what to do next, and your doctor will help you make that decision with you.
Absolutely.
Okay. All right. So the events that happened recently at Belmont Park, were they helpful in spreading awareness? I heard that was a big thing.
Absolutely. You know, we witnessed history at the Belmont Stakes for the first time in over, I guess, 30-some-odd years.
78 was the last Triple Crown winner.
We had a Triple Crown winner, and the Integrated Medical Foundation has a relationship with the New York Racing Association. And in fact, the week prior, or the Sunday prior, we had a run. Now, it was a little damp that Sunday, but we still had a lot of runners that were out. It's a great event for runners because it's one of the only times that people can actually run on the track. So the people that came out and for the 5K run walk were actually able to cross that finish line right where American Pharoah had done so, which is really exciting. So now that event already transpired this year, but it's an annual function that's done with the foundation in conjunction with NYRA and Belmont Park. They've been great in their support, and we thank them for it. So I'd encourage everybody who's interested in participating to keep a lookout because we do the event every year the Sunday before the Belmont Stakes.
Mm-hmm. Okay. So we've talked about the importance of getting screened. Where does one get screened? Where do they get a PSA?
Well, the easiest place to get a PSA test done is in their doctor's office, and that could be either at one of our offices at Advanced Urology Centers of New York. You can find those at AUCofNY.com, or even in their primary care physician's office. A lot of organizations do free screening, some around Father's Day, and there are a lot of free screenings that are being done in September, which is Prostate Cancer Awareness Month. In fact, we're working with Governor Cuomo. Looks like he's going to sign something that will formally designate September as Prostate Cancer Awareness Month in September. Around that time, they can go to the foundation website, which is imfcares.org, to look for places that have free screenings. We do it in many sites around the New York metropolitan area. Many church groups do it. And there's other entities other than IMF that offers free screening. But it's important that men not just simply wait for the month of September to think about this, or Father's Day. This is a 12-month-a-year problem. And prostate cancer doesn't wait for a specific month or a specific day to strike. So absolutely what I talked about earlier, where you should talk to your doctor about getting a baseline PSA and develop a proper screening regimen based on your own risk factors, every man should start thinking about doing that right away.
And again, for people who are just tuning in, to get a screening, and men are cringing when they hear about this, that involves simply getting a blood test, right?
A blood test that is generally combined with a simple physical examination, all of which takes not even a fraction of a minute.
Yeah, it's painless. Let's talk now about those who are diagnosed with some form of prostate cancer. What's involved with treatment there?
Well, for men that are diagnosed with prostate cancer, even advanced prostate cancer, we have more treatment options now than we've ever had. To start off with, we categorize prostate cancer based on risk, ranging from very low risk on the one end to high risk on the other side. So every man that's diagnosed with prostate cancer, they're not going to get any type of cookbook solution. Their treatment regimen is going to be customized for their particular stage and grade of disease, as well as their life expectancy and other health problems, what we call comorbidities. For a certain percentage of men, if the prostate cancer is very low grade or low stage, those that are at low risk or very low risk, it may be appropriate to defer therapy altogether, a process that we call active surveillance. Now, active surveillance is not the same thing as benign neglect. We're not ignoring those. We're actively following men to see whether or not the disease progresses. So we're not saying that those men will never need treatment. We're saying that we can safely observe them and defer immediate therapy, which is obviously less expensive and much less risky than active therapy. Now, for those men that need treatment, for some men, surgery is the best option, particularly if they have a very long lifespan and they're younger and more healthy. And for other men, some type of radiation therapy may be more appropriate. We're also doing studies to look at newer modalities of therapy, which are more focal and don't necessarily treat the whole gland, but those are still yet under development and need to be done under a protocol type setting. Even if you have advanced prostate cancer, if you have cancer that's spread to the bone, we have treatment options that work for that. And even for people that fail that initial therapy, we have, for advanced prostate cancer, we have newer treatment options that exist. Now, remember what we talked about earlier, Al. The 10-year survival, if you're diagnosed with prostate cancer right now, is 99.9%. So the therapeutic options that we have are very, very effective. And as we've gone on, they become much safer and with far fewer side effects. So no man should be afraid of facing prostate cancer. To start off with, they're not alone. We have a well-developed network of care coordinators. We have, in our own practice, we have a nurse navigator program that for a newly diagnosed patient with prostate cancer will basically take their hand and walk them through the entire process of coordinating their doctor's visits and getting their labs and making sure all the insurance referrals are right. We have the foundation, which provides support groups for men and their families across the New York metropolitan area. And we have a cadre of highly skilled physicians who can deliver the most sophisticated forms of surgery or radiation therapy, or if needed, chemotherapy to men that have the disease. So prostate cancer is a disease that can be overcome. But the most important thing that men need to remember is that the decision-making process for what they need to do about the disease should be in their own hands. And that first step is don't be afraid to go to your doctor and insist that you get your baseline PSA done.
There you go. Early detection is key in all of this, and a very high success rate. Thank you for visiting with us today, Dr. Kapoor. It's been very enlightening. He's the president of Advanced Urology Centers of New York and putting out a really important message we hope you heard today. You've been listening to Plug Into Long Island on 102.3 WBAB and 106.1 BLI.